Hello to everyone, and this is just a little conversation we're going to have about the role of mechanical power in ARDS mechanical ventilation. And I'm very interested to see a number of articles that have come up recently in the last 4 or 5 years, which really give us a very nice continuum in our treatments and strategies that we are offering to our patients. In the last 5 decades, 50 years of ARDS mechanical ventilation, we've learned and we've applied a lot of experimental and clinical evidence. And as a summary, these have enabled us to prevent barrel trauma and prevent ventilator-induced lung injury, such as occurs typically with a cyclical collapse and the reopening shear forces. They've enabled us to recruit alveoli using PEEP to limit the plateau pressures and tidal volume in a lung protection strategy from about 20 years ago, and also to minimize oxygen toxicity. And this whole collection really tells us that what we are doing is applying operator-defined set point targeting to our patients. All of them have some contribution to improving outcome and reducing mortality. So the question, when we are faced with all these proven benefits, what is it that we as the operator should optimize for our patients? Is it tidal volume? Because this can be thought of as a cost function that we are trying to target to try to optimize. And the tidal volume from the equation is going to be relational to the minute ventilation, the inverse of the frequency, and the dead space. And as we can see, as the frequency increases, then the cost of the tidal volume and the risk of ventilator-induced lung injury should go down. But obviously, there is a limit to what we can apply in terms of this formula. And in terms of the industry, most of our equipment is actually pegged, correct me if I'm wrong, at a rate of around 150 breaths per minute. Or should we optimize the tidal pressure, which would be the tidal volume that has been normalized to the lung mechanics? There is some evidence that the tidal pressure, which is the tidal volume divided by the compliance, may be a better predictor of mortality than tidal volume. And if you join the first equation to the second, this is what you get. There has been some studies shown at the bottom which associate the tidal pressure and the development of ARDS in mechanically ventilated traumatic brain injury patients, and also an association between tidal pressure and mortality in mechanically ventilated ECMO patients. So perhaps that is something to consider in the way that we are moving forward in terms of applying the technology that we have. Or could it be tidal power? There has been a report by Gattinoni and others of an association between the power that is transferred to the lungs and the ventilator-induced lung injury. And there has also been a slightly different view that from Marini and others, that it is difficult to link the power dissipated in the proximal airway resistance directly to noxious events at the alveolar level. In terms of the driving power, we can derive an equation based on the tidal volume. And we can also do that for tidal power. But I don't believe that there is really a dispute between these two ways of thinking. I think they are different. We are reading different paragraphs on the same page. And I think that in time we will, and I'm confident that we will be able to obtain a very neat way of describing what we are transferring to the patient, both proximally and at the alveolar level. And this is what I hope will happen in the near future. Moving on from there, we have now gained an understanding, again from Marini and others, that the driving power could be associated with the risk of ventilator-induced lung injury. And there is a recommendation that, such as power be normalized for the aerated lung capacity. And it's again possible using the above equations on driving power and tidal power to derive an estimate of the tidal volume, and using that estimate based on the dead space to arrive at somewhere around 4.4 mils per kilogram. So this is something that we could have a conversation about. Is it right to go in this direction in our future planning? We have been very fortunate that our recent engineering capabilities, plus a lot of research interests, have allowed a combined responsive interaction between the human respiratory effort and the mechanical delivery, or sometimes failure. And we have been um, able to derive this because of the work by Otis, which is now more than 70 years old, long before mechanical ventilation was in use, or ARDS, which enables us to combine the tidal volume and the pressure as a mechanical power, and from it to derive an algorithm which minimizes the work of breathing when we choose, for example, the respiratory rate and the tidal volume to maintain a set alveolar ventilation. Originally, Otis studied this uh, in patients, in normal persons with unassisted breathing frequency, to study the relationship with lung mechanics and alveolar ventilation in order to better understand the energetics of breathing and the associated effects all the way in the spectrum from normal to the disease state. And the hypothesis at that time was that the brain seeks an optimum frequency by a minimum breathing effort. There was an assumption of a single compartment lung model with linear compliance and nonlinear resistance. So we had an equation which allowed us to have an optimal frequency at the minimal breathing power. And about 60 years ago, Mead continued this work and also made an equation which was described as the optimal frequency at which the average force per breath required from the respiratory muscles is minimal. And these have now been taken on through technology and enabled us to achieve the first one about 20 years ago, called adaptive targeting, which has now been clinically proven in automated closed loop systems. For example, adaptive support ventilation, adaptive ventilation mode, and mid-frequency ventilation. And these really give us a sense of confidence that the ventilator is able to machine learn. It is able to identify certain characteristics in the patient respiratory cycle, which are then allow us to target a little bit towards an optimal targeting. And through that, there will be automatic changes applied in real time to achieve certain outcome predictions using algorithms which define the optimum target, such as a minimal cost function. It might be respiratory frequency or tidal volume. And we also have newer models of this in such as AVM2, which are based on an algorithm to limit the mechanical power which is applied to the lung in respiratory rate and tidal volume ventilation. And of course, in our vision, we can imagine that in the future, there will be an opportunity for artificial intelligence targeting, where the ventilator is able to apply neural network algorithms in order to deliver autonomous actions. As a clinician, we're very well aware that whatever we have, facility that we have available, we have to use it in order to firstly to protect all the processes that are very important in delivery. And then we will be able to apply our ability to protect in certain ways, such as with machine learning and adaptive technologies. And ultimately, we have to try and optimize. And what we are trying to optimize, I believe, is, as Marini and others and Gattinoni have said, we have to optimize the mechanical power delivery to the alveolus. So in the concept of mechanical power, I note that this means we are very concerned with the total energy delivered within a given time frame to the respiratory system, joules per minute. And we are also aware that the sum of forces which act on the lung surface during mechanical ventilation have been always defined by us. The respiratory rate, the tidal volume, the elastance of the respiratory system, inspiratory to expiratory time, the airway resistance, and positive end expiratory pressure, all combined in the power of the respiratory system equation. We of course assume in this simple equation that there is linear compliance in the respiratory system in the range of the operating pressures and volumes. And this power in the respiratory system has been suggested as a main determinant of the pathogenesis of ventilator-induced lung injury. There has been evidence that mechanical power is independently associated with mortality in the intensive care, the length of stay, and the hospital length of stay, the ventilator-free days in ARDS, and this allows us to carry forward the notion that we do have to concentrate on low tidal volumes and low delta pressures. Recently, I was very interested to read an article on mechanical power during veno-venous extracorporeal membrane oxygenation initiation, a pilot study by Belliato. It was stated that there is no standardized protocol for mechanical ventilation during veno-venous ECMO. And the question arose, how would we be able to reduce the mechanical ventilation forces on the lung tissue? What reliable measurements of lung tissue stress and strain might we be able to derive? Because we acknowledge that these are relatively difficult to determine in clinical practice. So the study involved a small number of patients in a prospective observational study in 3 centers over 19 months, receiving mechanical ventilation and veno-venous ECMO. And the parameters which were studied were mechanical power, the ideal tidal volume, respiratory rate, plateau pressure, P, inspired oxygen, ECMO duration, ICU mortality, and the length of stay. This is just a composite graph showing the major findings. And on the right-hand side in the corner, you'll see that I've highlighted that there was a significant reduction in the mechanical power from 32 to 8, and the plateau pressures, and the respiratory rate. and if before and after the institution of ECMO. So it appears that actually we are able to influence the amount of uh, energetics that is delivered to the patient under such conditions. And if we look at the comparison of these mechanical ventilator parameters in the first quartile of the veno-venous ECMO, and separate them into the survivors and non-survivors, we could see that the survivors, we were able to achieve a higher level of PEEP and a lower respiratory rate, as well as that there was a difference in the ideal tidal volume, suggesting that we are able to achieve a certain amount without damaging the lungs when using this technique. And we could also see that the study population baseline characteristics, there really wasn't very much else that was found on this, except that they had survivors had a lower SAP score, and but they also had a longer length of stay and veno-venous ECMO duration. Therefore, in the association with the ICU mortality, it came down to just a very important finding that it was a respiratory rate which was very significant as an a predictor of the outcome in this study. So finally, we could see that if we looked at the non-survivors versus the survivors, the respiratory rate was decreased, the PEEP was increased, there was a slightly increased ideal tidal volume, and a high respiratory rate correlated to an increase in ICU mortality. Non-survivors had a shorter length of stay, shorter ECMO, and lower PEEP and higher SAPs. So these quite interesting findings tells us that actually there may be a good reason for us to continue our studies to look at the way that mechanical power is distributed in ARDS lungs. And we have some evidence from simulated clinical scenarios which enable us to compare now a number of different technologies that are available for clinical usage. These are adaptive modes such as ASV, AVM2, and mid-frequency ventilation. They have been performed against the simulated clinical scenarios in the adult patients with normal lungs, with ARDS, and with COPD. And they do show the ability of the technology to optimize, to move towards an optimal target and to maintain that targeting across a range of ventilations. And this is also true. This has also been found when the simulation has been carried out on neonatal normal lungs, respiratory distress syndrome, and chronic lung disease. So my last slide is to say that I'm very, very happy and I'm very confident to see that these changes are occurring, and it will help us in the future so that we might, in tandem, work together very, very hard and be able to produce an improvement in the results which we all aspire to, which is to optimize the mechanical power delivery to the alveolus. And for that, thank you very much.
Patrick, thank you for your presentation. So, Robert, any input from that last set of slides since you're the co-author?
That is incredibly complex. You're not going to get much looking at that slide. And it, having written the paper, I have to go back and read it to understand what I wrote. But first of all, I want to thank Patrick for sort of endorsing the taxonomy of modes by using the names of the targeting schemes. I do want to point out that ASV, AVM, and the mid-frequency ventilation, MFV, those are examples of optimum targeting, not adaptive targeting. The ASV and AVM have incorporated adaptive features, but they're optimal in the sense that they try to minimize power transmission. Mid-frequency ventilation is designed to minimize tidal volume, or to either that or to maximize alveolar volume for the same inspiratory pressure. And it's all manual, so it's not adaptive in any way. But and as I wanted to call your attention to the fact that I have uploaded a file there for you guys. This is a paper that Marini came out with. It brings the concept of power optimization to the next level. So this just came out. It's not even in print yet. I think it's just the electronic version. And what they have done is they've created mathematical models that represent the flow waveforms for pressure control with a constant pressure, volume control with a constant flow, descending flow, ascending flow, and pressure control with a sine wave. And now the terminology that they use in this paper is somewhat confusing. It's not standardized, and I keep bugging John to get it right, but it's hard to teach a dog new tricks, with all due respect. But the point is, they calculated elastic power and total power as inspiratory time evolves. And as you can see, these flow waveforms generate vastly different powers within the cycle, right?
Yep.
And this dotted line represents some arbitrary threshold that could represent damage. And you'll notice that some of those, the damage they postulate would be proportional to the time spent above that threshold, or the area under the curve between the colored curve and the dotted line. And that would be, for example, yet another metric that you might find on the ventilator if we found that that metric was correlated with some bad outcomes. But this is right here is the cutting edge of what's going on in terms of this topic. And as I said, these guys just submitted another paper. I don't know to what journal. I think he did it today, and you'd want to be watching for that. Of course, it probably takes 6 to 8 months before it comes out. But
yeah, on that previous paper, they had raised this theoretical threshold as well, and they had presented it in relationship to a volume-based breath. So it seems like they're progressing.
They're evolving. They realize that there are other ways to ventilate people.
Yep.
I don't know about you guys, but in our institution, whenever a therapist puts a patient in volume control, 99 times out of 100, they use a descending ramp. And I ask them why, and they can't tell me why. They say it's more comfortable, but that's bullshit. They really don't know why they're doing it, all right? I have theoretical reasons why it might be beneficial, but what do you guys see?
Intuitively, I've always felt like at the early part of the inspiratory cycle, I was things were more forgiving because of the resistance of the endotracheal tube hub and getting through the airways. So I was always had a tendency to use decelerating flow, feeling like early part of that phase. Now, next week we're going to have Steve Don join us, and some of the work some of the presentations he has put out there really caused me to think twice now about my old ways of ventilating. But it's related to the same concept that damage is done near the terminal end of that breath versus the early phase.
Well, that's what these guys are trying to say. It just depends on what flow waveform you're using, right? Yeah. He has invented this term called intra-cycle power, that you can plot power not as a digital number per breath or over a period of minutes, but power per second during inflation. It's just an example of how you put a concept under the microscope, and the more you see, right? And it just seems like just yesterday we started to focus on work, and then the next level was power per minute, and now it's power per second. Pretty amazing.
I wonder, is anyone aware of any work being done to look at cumulative effects of power versus, breath to breath or minute uh, related elements? I know that Gattinoni and Marini, in their 2020 article, referenced that there was no proof, that there was no indication, but that there was some thinking in that direction, that there may be a total cumulative power number that we do not want to cross past.
Yeah, and it starts to get complicated in terms of the terminology because power is a cumulative index. It's the cumulative work over per unit of time, right? Over a
Right.
minute.
Yeah.
Or as you might argue, as Marini is now, that there might be another index. Okay, so it's the cumulative time spent at power above some critical threshold. So that would be a cumulative index. And needless to say, these are still in the very early theoretical stages. And they're running these on physical simulators, but we don't even have any animal models to test these theories out. So it's going to be another decade before we get answers to questions like that.
I also think what Marini is showing in this paper, just scanning through, which is really nice. It's one of my skepticisms of the power has always been that it is that unit of time, that it's basically an average of the power over a minute, but what the lungs actually experience, how the lungs experience that power.
Yeah, and furthermore, that's just a single compartment model. If you're talking about a multi-compartment model, now you're probably talking about multiple peaks, right? Some alveoli are below the threshold, and some are above the threshold, and some are in between for the same breath. So it's much more complicated than our brains can really appreciate, I think.
So I've always thought the important thing is probably we want the power to be as low as feasible, but at the same time not overly reassure ourselves that we're the way, because the way that power is delivered throughout that minute,
exactly,
it can be very different, can be injurious in some and non-injurious in others.
And what Marini is showing in this paper is not over a minute, but over less than a second, right? Less than 0.8 seconds of an inspiratory time.
I was going to say, Andreas, you've been very quiet at the moment. This is one of your babies, is it?
Look at it. One of the main, argument is that we're trying to put a number power into a clinical context, and all what we know is a predictive value of that number. I don't like the word association. That is probably giving us the wrong impression that by reducing that number on the ventilator, like reducing the tidal volume, manually reducing, may make the patient healthier or better. What we all know is that these algorithms and measurements, they're only predictors of outcome because they haven't been tested against a robust trial design, like a randomized controlled trial, where you intentionally reduce the power and then assess overall outcome. So we're still sitting here in the in the physiology and trying to explain, but the clinician wants to know if I have a power knob on my ventilator, if I turn that down, will I have more survivors? And the paper on VV ECMO with a reduction in power delivered and the difference between survivor and non-survivors is fairly simple, that the survivors had better lungs, more compliant lungs. and hence not surprising that you could ventilate them with a larger tidal volume, lower power needed to generate, because the numbers looked favorable in their case. So I would be very cautious about taking too much out of these papers, because they're only predictors or numbers that predict. And the only way that I can see that we can do similar studies or similar outcome studies and not necessarily doing a randomized controlled trial is a propensity matched analysis of a large group of patients with these type of numbers on power and tidal volume, etc., obtained. I think that, as clinicians, we will say yes, and so what? Because I can't influence that number. It's driven by the patient or the lung physiology.
Yeah, what you said there is very important, that correlation does not imply causation. And in science, it's very difficult to prove causation of anything. My interest in this is the fact that minimizing power is something that the brain has evolved over 100,000 years. So there's that, right? It's hard to fool Mother Nature.
Yeah, and I fully agree that, and I think you mentioned as well in your paper that NAVA as a measurement of the effort of breathing is probably the closest that we can get to understand what the brain actually wants to do.
Yeah.
And obviously it's not going to work if you have paralyzed patients. Right. So you need to have them. I've worked on some of the NAVA signal, sedation, hangover from paralysis, etc. Hugely affects the signal or the brain, and then it becomes null and void. So until we have indeed a probe that we can stick into the medulla oblongata and
it's called Neuralink. Let's go talk to Elon Musk.
Yeah. Sorry.
So I think that and one of the key elements is that I think that experts do understand and the concept, and it has evolved over since the first from Roger Mead and Odie's equations, that we are on the right track, but we have failed to demonstrate if we can control what we intend to do is making a difference. And just one side comment that, we're starting to talk about 4.4 mils of tidal volume for adult ARDS ventilation. I'm always taken away by the neonatologists with the volume guarantee or minimizing volume. 4.4 is exactly how you ventilate a preterm infant. And that's been there now for, I'm guessing, 10, 15 years.
That's why ventilators can go up to 150 breaths per minute, because you can do that on a neonate.
Yeah.
We actually had one human study on neonates of mid-frequency ventilation, and they pushed the rate up to 100, 150, and it worked.
Yeah.
And you can get away with that because they have such a very short time constant.
One of the things that we quite commonly forget is as well that we underestimate the convection diffusion front distance that when we go from bulk flow to diffusion. Where is that barrier of the convection to diffusion happening? And obviously in a neonate, you've got we're talking about a distance of 8-10 centimeters down to the lowest alveolus, where in adults we have a much larger distance, and that's probably why HFO, high frequency ventilation, is working well, because we don't have the same problem with the diffusion distance.
Right. Exactly. My experience has been going clear back to the 1980s. That high frequency ventilation, jet ventilation or oscillation, does work on preemies much better than it does on adults.
There's no question. And we, working in pediatric ICU, I can tell you that I'm very happy to put a 2.5, 3 kilogram patient even on after cardiac surgery and HFO. But as soon as we get into the teenage, bigger bodies, 50, 60, 80 kilograms, I'm less confident that HFO is a lifesaver.
I agree 100%. That was my experience when I was doing clinical work back in the 80s and the 90s.
Yeah.
Hasn't changed much in all these years.
I'd like to ask Rob, is there any prospect in which developing a multi-compartmental model may allow us some further insights into the regional power distribution?
Yeah, absolutely. That's probably going to be the next phase of research that I do with Marini. In the current paper that he submitted, I did a validation of his mathematical models using the Ingmar ASL 5000 lung simulator, but it was set at a single compartment model. Now you can use that simulator and you can program it to do a dual compartment model. One with a normal compliance, let's say, and one with a very decreased compliance. And I would think that the next step would be to just repeat the experiment that you see that I just uploaded, or the paper that's coming out, with that kind of model. And what I'm expecting to see is that you'll have, instead of a single intra-power curve, you'll have two. And maybe one will go above the threshold of injury and one will not. And just depending on how different the time constants are. Now, I will also tell you that in the works, Ingmar Medical has been working with a company called Kitware and a guy named Jeff Weber, who has created a simulator, a physiology simulator. It's a free physiology simulator, and he can program it to have all kinds of outputs for all kinds of inputs. It also has a virtual ventilator built into it. So you can set the virtual ventilator in the simulator and get blood gases, for example. And the blood gases will reflect the disease state, whether it's a normal lung or COPD and ARDS. And I've helped him to validate that model. And Ingmar is looking to integrate the physiology simulator into their mechanical simulator. So that would be the next step. Then if you have a dual compartment model with each has its own VQ ratio, what's going to happen in terms of mechanical power distribution for a given level of alveolar ventilation and blood gases that you want. So yes, I think, as you guys know, I mean, simulation is becoming more and more important in medical education and exploration and research along these lines. What I'm seeing, what I'm involved in, is moving from simple mathematical simulations to more and more complex physical simulations and physiology simulators. And in many ways, it's quicker and easier to get a general understanding of what you're doing than trying to go into the animal lab or God forbid, doing it on humans, So yes, the short answer to your question, yeah, that's what we have to do next.
Good to know that, Rob.
Could I make a couple of quick comments?
Please.
Patrick, thank you for a very nice presentation, and thanks to everyone else for the comments and helpful information. I was looking at the article that Patrick, that you reviewed, and had some thoughts about that article specifically. One is that as I read it, I sort of assumed, although they didn't directly state it, that basically the hypothesis was that lowering the mechanical power after initiation of VV ECMO in ARDS patients would probably lead to better outcomes. And to the extent that the papers, the results of the paper are believable, that wasn't found to be the case, although individual parameters of ventilatory settings were. But there's kind of a mathematical coupling in the formula that they use for mechanical power that I think is worth looking at. So one of the products in the equation is the difference between the peak pressure and 1/2 of the delta P. So that leads to sort of a paradoxical situation where the lower your delta P, the higher your mechanical power. Now we can couple that with the notion that we have that delta P, which is also driving pressure, seems to be correlated with outcomes in ARDS. So it's possible that that may be one of the explanations why mechanical power wasn't directly correlated with outcomes in this trial. And then as a clinician, if I think about how that works and the fact that a higher PEEP seemed to be correlated with a better outcome in this small study, when and I think many other clinicians are using a higher PEEP, we're probably still keeping an eye on the plateau pressure and trying to keep that below 30 or even lower if we can. And so what that means is if you have a higher PEEP, you're going to end up with a lower delta P, right? And that lower delta P is going to cause artifactually your mechanical power to be elevated based on this equation. So that conflation may be possibly playing a role in some of the outcomes here in the study.
Yeah, and the other thing is that was just a very simple approximation for power. And it may not have been the best model for calculating power under those ventilator circumstances.
Right. And then a second comment would be, and this is a little bit of a digression, but I'm remembering when Luciano Gattinoni gave his address at the Society of Critical Care Medicine meeting here a number of years ago when he was awarded a Lifetime Achievement Award. He was talking about the ultimate feature of mechanical ventilation, and basically just came out and said that the ultimate future of mechanical ventilation, the ultimate optimal mechanical ventilatory support is zero, none. And you know, I think most of us would feel that that's probably the least likely scenario for causing lung injury iatrogenically. So we, in our own ECMO program, have been following the lead of some others in the country and now around the world, especially this group in Rush and Chicago. And in the last month, we've extubated 3 of our COVID patients on ECMO so that they're now, they have been breathing, you know, on their own using nasal cannulas or high flow nasal cannula to breathe. And one just went home earlier this week, and the other 2 will probably leave in the next couple of weeks. So I think that's an exciting element for the future. I mean, obviously, many of these patients still have to be mechanically ventilated even on extracorporeal support, but in selected cases, we're able to literally completely remove mechanical ventilation. And I guess then the final thing would be then the only risk of induced lung injury would be self-induced lung injury, if that's a real thing, if we know how to define that or prevent that or what have you.
I can't remember exactly the title. There's quite a nice animal model where they, I can pull it out, where they looked at spontaneous breathing and transpulmonary pressures generated by these animals and CO2 control. And they could actually demonstrate that when you have them self-ventilating, the so-called the transpulmonary pressure generated by these huge efforts that these animal developed caused more lung injury than when they would have been ventilated. We've extubated as well older children, because younger children you can't during ECMO, but we found that quite often we had to reintubate them because they started to get quite huge respiratory effort and actually struggling to breathe whilst being on ECMO. So I'm always a bit cautious about the, you know, every unit has their success of extubated patient on ECMO, but I think we should as well report the non-success, because we had a few that we extubated and had to re-intubate again because they struggled. So when you go and ask people, it's worthwhile asking, how many did you have to re-intubate again?
What do you think is the stimulus to breathe?
The argument in that animal paper was, even if you have the CO2 controlled with ECMO, so there's no CO2 or pH related reason for increased work of breathing, they still were generating quite significant work of breathing when they were spontaneously breathing, and they contributed to pressure related signals sent to the brain that is as well, controlling the breathing. So keeping the CO2 in the normal range, or in the range that you wouldn't expect gasping for air, they still did.
Yeah, there was I think you might be referring to the sheep study done by Ted Kolobau in the late 80s, where they were able to induce acute lung injury by instilling an acid in the cisterna magna or somewhere in the brain. There was an interesting interview with Martin Tobin on a podcast, MCRIT, which I listened to quite a bit, which was last summer, and they were talking about respiratory failure and COVID-19, and Dr. Tobin was commenting on the question of self-induced lung injury and whether it really exists. And what Tobin said, and he's way smarter than me, and what Tobin said was that self-induced lung injury and spontaneously ventilating humans is a hypothesis based on that study and some limited human data. And so it sounds like he's somewhat skeptical of that, but nobody knows. As he says, right now it's a hypothesis, but I worry about it. And it's been a big issue in the COVID pandemic in terms of how long we wait to intubate patients who are breathing fast and deep and exhibiting excessive work of breathing.
I mean, any anesthetist or is quite well aware of airway obstruction. You generate fairly quickly lung edema, and so there must be some relationship between the self-introduced work of breathing and lung injury, because we can observe it with upper airway obstruction within minutes. So if I could relate that there must be some form of self-inflicted lung injury just based on these observations, that healthy lungs, upper airway obstruction, pulmonary edema fairly quickly. Would estimate that a sick lung is even more prone to generate or inflict own injury if the work of breathing is too high.
Okay. One thought I had while David was talking about the ECMO paper, actually, and the fact that it sort of attributed that the reduction in mechanical power didn't seem to affect the ECMO. I wonder if that's the right question to ask, and should the question be more related to what's the mechanical power before you go on ECMO, and could it actually be used as a measure to determine, like, if we can't acceptably ventilate this patient with this level of power, is this the cutoff at which point we move over to extracorporeal support? I wonder if that's the question we should be asking.
Yeah, but then you'd have to sink an esophageal balloon or something like that, right?
Yeah, maybe.
So PDP, huh?
Yeah, you need a pressure measurement. It's not just about the tidal volume.
That raised another observation I had in thinking. Obviously, as a developer, I'm taking this data and trying to think about what really is available, especially in adaptive modes. It seems like in so many of these modes, the user is asked to pick a minute ventilation and a respiratory rate. And when you then look at how that fits into the equation, the thing that's left for the ventilator to work with really is driving pressure. It's really or P control if they're in pressure control, or flow control if they're in a square wave. So it kind of boils down to those two pieces in some simplistic way. It seemed like to me, but like I said, you guys are way smarter than me, and I was just trying to figure out what might be next for ventilation mode development. Okay, guys. Well, thank you so much. Again, Patrick, thank you. And Andres, thank you for joining us. We appreciate you, having time to join us. And we're looking forward towards a presentation from you as well. But gentlemen, stay safe. We're almost out of this pandemic. So I hate to be the last guy shot in an armistice, right? All right. Take care.
Okay, thank you. Thank you all very much.
Bye.